Hello from Montreal. My name is Kirsten Johnson, and I am an emergency physician practicing at the McGill University Health Centre Hospitals. And I am also the incoming president for the Canadian Association of Emergency Physicians starting this June. I'd like to welcome everyone to CAEP's first national coronavirus town hall. It is a pleasure and privilege to be here tonight and to be able to facilitate this important event that will draw upon the knowledge and experience of CAEP's leaders and experts in emergency department flow, public health, disaster response, wellness, and infection protocols, amongst others. We intend on hosting a CAEP COVID Town Hall weekly on Tuesdays at this time, and we'll hope that you will find this one useful and continue to join us. The format of this event will be brief presentations by each of our 6 experts. We have received many questions from you, and we've divided those up amongst our panel so that they can address your questions that pertain to their area of expertise. This town hall should take about an hour and 15 minutes and will be recorded and available to listen to immediately after this presentation on the CAEP website. Speaking of which, we've amassed a wealth of COVID resources on our website that include protocols and literature, and I would encourage you to check it out if you haven't already. These resources may prove useful to your practice or emergency department. They're updated daily, and if you have something you would like to contribute, please contact Christina Bova. Her contact information is on the website. The website also houses all CAEP's position statements, and a number of them pertain to COVID. For example, CAEP has posted statements on safe working environments in hospitals during the COVID pandemic, COVID-19 in regards to rural emergency departments, and today we posted 3, including the Canadian Emergency Department Statement, another on surge capacity, and a third on persons experiencing homelessness or vulnerable housing during COVID-19. I wanted to remind everyone that due to COVID, CAEP's conference for 2020 has been put on hold. We'll be sending out more information shortly. Regarding conference refunds, you might consider donating all or part of your refund to CAEP or to its Emergency Medicine Advancement Fund, or you can leave it with CAEP for future courses or our next conference in 2021. It is a strong membership that allows CAEP to provide you with COVID-19 town halls, a robust information center, and all of the advocacy efforts to date. Thank you to all those who have joined or renewed this year. It is crucial now, more than ever, to strengthen the voice of emergency medicine by becoming a CAEP member if you are not one already. You can join or renew at caep.ca. If you need assistance, you can contact Christina Bova directly. Her information is on the membership page. Okay, so now on to the main topic of the evening, COVID-19. Today, around the world, we have 378,741 cases, 16,496 deaths. In Canada, we have 2,590 cases, 25 deaths, and 112 recoveries. Our curve has been increasing exponentially since March 12th, with a large spike in yesterday and today's numbers, mostly as the result of an increase in testing. On March 23rd, we had 621 new cases, and today we have 499 new cases. Quebec has the largest number of cases at 1,013. Ontario and British Columbia are not far behind with 588 and 472 respectively. Ontario and Quebec have stopped everything but essential services for the next 3 weeks to try to hammer down the curve with strict social distancing measures. We are waiting to see if the rest of Canada follows suit. With this in mind, I'd like to introduce you to our experts tonight. We have Dr. Eddie Lang, who is chair of CAEP's Leadership and Stroke Committees. He's a professor and department head for emergency medicine from the University of Calgary Cummings School of Medicine and Alberta Health Services. He is also the scientific director of the Emergency Strategic Clinical Network. Dr. Daniel Kollick is chair of CAEP's Disaster Committee and associate professor at McMaster University in Hamilton, Ontario. Dr. Roderick Lim is chair of CAEP's Wellness Committee and medical director for the emergency department at the Children's Hospital in London, Ontario. Dr. Trevor Jane is an assistant professor of emergency medicine at Dalhousie University in Nova Scotia and program director of the Bachelor of Science program in paramedicine at the University of Prince Edward Island. Dr. McGinty is a clinical scholar in the Division of Infectious Diseases at the University of Ottawa Hospital and a fellow at the Ottawa Hospital Research Institute. And Dr. Krishan Yadav practices emergency medicine at the University of Ottawa and is also part of the Ottawa Hospital Research Institute. So without further delay, I'll let Eddie Lang start the presentations. Thank you.
Thanks so much, Kirsten. And I really wanted to congratulate CAEP for bringing us all together. I see there's about 230 people on the line right now, and I think the recording will be viewed by many more. This is just such a critical time, and the opportunity to hear about what's happening across the country is essential. So I've been asked to cover three topics. First is the operational nuts and bolts of what your emergency department will be transforming into, if it hasn't already, in preparation for COVID. I've also been asked to touch a little bit on PPE resources, but actually a lot of that is going to be covered by Krishan later on in the presentation. We're going to also cover the topic of dealing with staff who are in isolation, and I also wanted to speak a little bit about vulnerable physicians. So you'll find a lot of what I'm going to talk about on the CAEP webpage, as well as on our University of Calgary webpage. But essentially, what's going to happen is your emergency department is going to transform in a functional way that will limit COVID exposure. And you're going to create a narrow corridor of service for suspected COVID patients, so that you are at all points limiting the amount of virus that other staff are exposed to, that other patients are exposed to, or that are entering the hospital in an uncontrolled way. So currently what we're doing in Alberta is we've set up at the front door of the hospital places where staff are getting their temperature checked, they're getting forms filled out, and access to the building is really quite limited. As you approach the emergency department, a pre-triage station will be there to find out exactly what brings you to the hospital and see if you're going to be going towards more of a COVID type of an evaluation or more of a regular evaluation. And I'll tell you that even that distinction right there is fraught with some risk, as we have had some presentations that appear to be non-COVID related and turned out to be COVID after all. Staffing is going to be a big issue. We have currently a number of physicians who are off because of recent travel, or they are currently having sniffles or respiratory tract symptoms, and they're in isolation while they're waiting for that to clear or waiting for their swabs to come back negative. And so planning for that contingency and working with staff and finding things that staff can do to help support what's going on right now is critical. The other issues are coming up relate, of course, to the high-risk population in nursing homes. And Calgary declared its first death today, which was a nursing home patient who had come in contact with a staff worker who was positive, but was really asymptomatic. And that patient had limited goals of care and actually expired in the nursing home a day or two after presentation with the initial symptoms. So I think that tells us about how rapid the progression can be in that population, and the possibility of thinking about forward deployment type strategies. Some of your jurisdictions will have community paramedics, and thinking of sending folks, paramedics, into the home to do evaluations and maybe even provide palliative care on site to limit transport of COVID patients to hospital may be critical. The other thing we're looking at is limiting visitor access to the emergency department itself. And that includes, and this is not easy, but keeping some of the children out of the hospital if they're out of the emergency department, if they're coming in accompaniment of parents. So, I'm sure you're all developing your own unique plans that are relevant to your circumstances, but the general principle remains to separate the emergency department into COVID and non-COVID zones. One of the issues we're struggling with right now is where do you need PPE resources and what kind of PPE do you need to wear? That's actually being discussed at the highest levels right now in Alberta. I mean, it's very clear that if you're in an area where swabbing will occur, or you're going to have COVID or rule out COVID patients, you'll need to have a procedure mask, eye protection and a gown and gloves to evaluate these patients. Whether that extends to the whole emergency department, I think still remains a matter of controversy. One thing that may be coming down your way quite shortly, and you may know about this if you're tuning in from Alberta, is that we've just announced last night that we are no longer going to do widespread testing, including in the emergency departments, for patients who are at low risk and in whom discharge is anticipated. So we're now only going to be testing for COVID with nasopharyngeal swabs on patients who are being admitted to the hospital, or for healthcare workers, or for patients going back to long-term care facilities, or staff that work at long-term care facilities. So huge amount to cover on Operation Nuts and Bolts. Hope I gave you the big picture. Let me move now to what's happening, and it's a bit of a more of a positive story on our physicians who are in isolation by no fault of their own, simply because they had travel plans that brought them back during a period where you needed to self-isolate. So we are fortunate, and I think Rod will probably touch on this. We have a wellness group. They've been putting together a plan to make sure that these folks are okay, see if they need to have meals delivered to them through the Meal Train app. A lot of the Emerge docs whose teenagers are now off are putting them up for sale as babysitters to have the parents who have younger children and who need to work and whose children are now back from daycare and from primary school to be able to look after them. Also, what we have is 240 physicians in our city who have volunteered for contact tracing. So every day we identify, at least in the last few days, anywhere from 30 to 60 new cases in the province, and these are immediately subjected to contact tracing activities where the volunteer physicians, typically those in isolation who aren't doing much else, are calling patients, finding out where they've been over the last few days, and making sure that everyone they've been in contact with is either in isolation or monitoring symptoms. I'm going to finish up with a discussion around vulnerable physicians, a really sensitive and difficult topic. And of course, as you know, that as emergency providers, we are already at high risk for illness due to COVID, and that is probably that is definitely higher if you're over 50, over 60 especially, and if you are immunosuppressed for whatever reason. So we've struggled with this, and I know a lot of other groups have done as well. And, it makes me reflect on how this crisis is really bringing out the best in people. So a number of groups across the country, as we've heard, are allowing these older physicians, if they're not comfortable with working in these circumstances, to allow some of that slack to be picked up. And clearly we can't have anyone working when they're not feeling safe or not feeling comfortable. So of course it creates challenges in some environments where there's just not sufficient staffing to make allowances for those who have potential vulnerabilities. We also don't want to be sending the message, because it's not an accurate one, that adequately placed PPE is almost foolproof in protecting you against nosocomial infection. Almost all of the cases in Italy occurred because of a shortage of PPE or because of inadequate preparation. So I think we have to be careful on that front. So I'm going to end right here. I wanted to thank my leadership team, Neil Collins and all of our site chiefs, Karen Foodie on the nursing side. The province and our zone in Calgary is coming together in an incredible way to prepare for what can only be described as a very challenging situation. Thanks for the opportunity. Please feel free to be in touch if you have any questions or want to know more. Have a good evening. Looking forward to the rest. Daniel, over to you. Dr. Kollick in Dundas, Ontario.
Hi, folks. I'm going to just bring my screen up. I'm going to be talking about flowing in the department. Just one moment. Okay. So I'm going to talk about ED flow. The objective is, how do you improve your flow with a focus on dealing with COVID patients? And I'm going to build on what Eddie said. I'm not going to cover clinical guidelines. I'm not going to cover generating extra surge space or global hospital flow. Those are other topics. We can get to them if we have to, but not under this presentation. Key points, I'm going to talk about triaging. First, triage into stay or go. Second, into respiratory or not. I'm going to expand on scalable, dirty, and clean zones, define triggers, and I'm going to talk a little bit about care protocols and their role. So the first thing, if you want to flow people through, is you have to decide who has to come in at all, and that's the stay or go part. This is not something that the nurses are typically used to doing, but this has to be something we empower them to do. And I'm going to expand on that in a moment. The second one is triage into respiratory or not. These are decision points. They don't have to be separate areas or separate people. You can have one person doing both, but that's a sequence it has to happen in. We have to define ahead of time what the criteria for discharge are, and we have to empower the triage nurse to do so without having a physician there. This is a cultural change for the nurses. They're used to having us discharge patients. We need to cover them and make it very clear. Patients who fit certain criteria do not need to come in, go to an alternate area. The second triage is into respiratory or not. And from this point, the patients are treated in physically different areas. The clean area will be for the non-respiratory patients and the dirty for the respiratory. Right now, I'm using respiratory as a proxy for COVID. We may find over time that the criteria for COVID isolation changes, and that'll have to change this as well. But right now, we'll just call it respiratory yes and respiratory no, with no testing. Just if it's respiratory symptomatology, even if that's not the key complaint, they're considered dirty into the dirty zone. If you look at it graphically, if a patient shows up, get to the first triage. If they fit the criteria for discharge, they go home. They have an advice sheet that includes the indications to return to the emergency department. Some places are talking about doing oximetry at home. Whatever the criteria are, make them clear. We're not saying don't darken our doors again. We're saying right now you don't need us. If they pass that hurdle and they need to be seen in triage, need to be seen in the emergency department, we divide them into no respiratory symptoms. They go to a clean area where treatment is as usual. I'm going to expand a little bit on that, but that area does not require the staff to wear the same level of PPE. If they have respiratory symptoms, they'll be divided into 4 areas. Some of these can overlap. Different hospitals will have different protocols, but generally speaking, those requiring oxygen that might be discharged, those requiring oxygen that are going to be admitted, those requiring non-invasive ventilation, and those requiring intubation. A word about the zones, generally speaking. Staff and equip them to match acuity. In other words, if you have the zone with a low acuity patient, that is not where you put your most experienced staff. That's where you put your more junior staff. There's been some talk amongst the questions that we got about medical students and their roles. People who are less experienced, such as medical students who we feel would be appropriate, would go to the low acuity patients, the low acuity zones. The clean and dirty zones are physically isolated from each other. There's no crossover. It's like hot and cold zones in decon. You don't go from one to the other unless you're cleaned. Triggers. You have to have criteria to know how much you're going to use for each zone. Initially, we may need fewer beds for the dirty zone, but as the numbers change, we may want to scale our dirty zone up and our clean zone down. That's something you should probably think of ahead of time in your context and think, if I have 10, 20, 30 patients of a certain type, this is how my ED is going to be divided. The clean zone, by the way, does not have to be on site. The clean zone could be adjacent, could be another ward, could be whatever, just to keep that in mind. Every individual zone has to have a care protocol. Try and set things up so that everything is set up, is defined ahead of time, just like we do delegated acts for nurses at triage, that they can x-ray certain things and so on. Try and map out your treatment plan as specifically as possible, because there's going to be a shortage of physicians, and if we're able to have the decision made ahead of time, it saves us as a resource, and the nurses are able to go ahead and do stuff without waiting for us and consulting, and that'll flow people through faster. Now, as I said, we need to have, just going to expand this a little bit, we need to have criteria predefined for who gets discharged from the dischargeable group and who could be discharged if we have this criteria in our treatment plans. If we give them oxygen, what are the criteria for discharging them? And that means that they can be sent home without consulting a physician. The clean area. Remember that, as I said, it can be off-site or adjacent. Our hospital now has a policy that all patients presenting are masked. There's some questions about that in the questions we got. As opposed to us wearing one mask all day long, we're actually masking the patients for the time that they're in the department. I know this is a hot topic. The other thing about the clean area, keep in mind that whatever you design as your clean area still has to accommodate all levels of care, albeit hopefully in smaller numbers. That includes monitors, lab, ability to access, and the ability to do small procedures, sutures, reduction, and so on. Anything requiring can aerosolize, and here I highlighted the non-invasive ventilation. That's also true for the high-flow nasal cannula, which we're going to get to later on. Needs to have a dedicated room that is isolated so that the staff in there wearing appropriate PPE are not, it won't aerosolize to the rest of the department. So, in summary, we need to have the predefined criteria for discharges. We have to have the clean areas that can accommodate all levels of care. They don't have to be in the building. All clean area patients are masked. We have to be able to isolate aerosolized areas. And remember, divide into zones, predefine the tasks so people can do stuff ahead of time without asking you, and have everything as protocolized as possible. And that's where I'm going to stop.
That's great. Thank you very much. My name is Rod Lim. I'm the chair of their wellness committee. I'm just going to share my content here. So we're going to talk a little bit about wellness in the time of COVID-19. I just want to acknowledge that it's an extraordinary time for all of us. And I think we're right now in fight mode. We've been spending a lot of hours planning and kind of watching the news and awaiting the, hopefully not tsunami, but the storm that is ahead of us. But I think it's really important just to acknowledge that during this marathon, there's going to be a tremendous amount of mental distress on ourselves and our patients, our community, and our family. And I think it's important for us to be hyper aware of this. There's going to be a lot of exhaustion during this process, and I think it's just super important to try to get things in line now, to consider to develop structures that will allow your group to connect and to work through problems in a very efficient manner. I just want to spend a couple minutes talking about a statement that's going to be coming out from CAEP regarding physician health and wellness during this pandemic. And I'm going to talk about it from a macro and a micro point of view. Macro in terms of that there are huge system issues and things that need to be fixed and moved in a proper direction for us to feel better about our chances of the greatest success through the next period of time. But also on a micro level, in terms of thinking that these factors are probably things that are causing a tremendous amount of stress amongst yourself and amongst colleagues, and what are the things that you can control within that that can alleviate some of the stress. So 4 main points that we want to bring through in terms of the statement. Protecting the health and safety of the emergency department staff is paramount. As part of that, I'm sure a huge degree of anxiety amongst the people you work with and yourself is PPE, which we're going to talk about as part of this in the following speaker. But in terms of the clear direction as to the proper scientific protection that's going to safeguard yourselves, prevent you bringing it home to your family and to your colleagues. The supply chains and getting proper information about what the supply chain looks like for you and your department is a great deal of anxiety. And this statement really talks around that. Consistent triage protocols. A lot of misinformation or rumor mill is very, very disturbing to the group and to yourself when you hear another hospital maybe doing something different with their travel restrictions compared to your hospital, or their PPE compared to your hospital, or another department compared to your department. A lot of these fragmentations are very, very disruptive, and attempts to minimize them and getting clear, consistent language is very, very helpful for you and your staff. In terms of supporting physicians that are increased risk, Eddie talked a little bit about in terms of age or immune compromise. I think addressing the physical needs of ED staff, whether yourself or your staff, is super important. Whether that's food, sleep arrangements. In terms of some countries have gone to where the healthcare workers were not going home afterwards, and where could alternate sleep arrangements be made in that circumstance. Security of the department in terms of screening and safety helps alleviate some of the anxiety. Moving on to optimizing emergency department human resources. The statement talks a lot about in terms of funding and resources dedicated toward emergency. And I'm sure you're rallying your local hospital and area to optimize those resources. A lot of angst amongst our trainees in terms of their certification exams. I know in academic centers that's caused a huge ripple through the group. In terms of a flexible and rapid system to try to coordinate ED staffing across the country, because we know that different parts of our country are going to be hurt in different ways. We think that trying to remove some of those roadblocks to be able to move the human resource of physicians or whatnot would be very beneficial in order to provide the greatest help. The next one talks about ensuring access to counseling and emotional support during the pandemic, and just as importantly, in its aftermath. We're advocating very hard for paid counselors, social workers, assigning specific counselors to hotspots across the country, virtual counseling, expansion of paid mental health benefits for frontline healthcare workers, and 24/7 health hotlines. These are all important, and we'll talk a little bit about the slide about things that have come through volunteerism and some of the supports that are going to be available in your community. But it's super important to think about it early rather than late. And just the last point in terms of the statement itself is the central authoritative source for dissemination of information. I think this is a good example of trying to provide information uniformly across the country, but a lot of variability is very difficult to reconcile, and it creates a great deal of anxiety. And whether that's related to self-isolation and travel, choice of PPE or whatnot, it would be good to have a centralized authority or messaging to alleviate a lot of this fragmentation that's happening. Super important to think about physician and staff wellness. We are just in the beginning phases of what is probably going to be a prolonged period of extraordinary times. And already the level of anxiety and worry that we're witnessing is coming into the forefront. I know from a patient point of view, it's eerily quiet. I know where I'm working, it's eerily quiet. And a lot of patients with medical disorders and mental health disorders are not choosing to come to the emergency department now. But we know that especially with a lot of social distancing and with a lot of non-access to primary care, I think they're going to come in a lot worse than they normally would after that period of isolation. So from this point forward, it's really, really important that we talk about checking in with yourself to see how you're doing, with each other, with your family, and really checking on everyone's well-being. I think it's really important to create structures to connect virtually. I know we've quickly converted a lot of our normal email and messaging communications between us into a lot of apps, whether that's WhatsApp or Slack or whatnot. Converting to that is super useful. I know personally we've developed one for our within our medical leadership. We've created one within our nursing leadership. We've created one when our members got an exposure and were quarantined. We created a network just for them. And even checking in on them virtually through that network was very useful. I was quite surprised that they were affected after quite a few days of isolation. And that ability to connect with each other was really crucial and helpful for them to feel like they knew what was going on and were supporting each other virtually. So really leverage that technology to form those connections, because even though we're physically distancing, which we should not be socially distancing, and as the time goes longer, certainly that becomes more and more important. I just want to highlight that There's lots of provincial resources and territory resources that are available. We've tried to update them to be current. This is being recorded. You can go through the webcast and refer back to some of the resources that I'm going to be talking about. This is on the CAEP website, both on the COVID webpage and on the CAEP Wellness Committee webpage. And there's a direct link that's on the screen right now. There is a very good article the CMA recommends about how to talk to your kids about COVID-19, especially as a healthcare worker going to work. I know from personally that is a great source of anxiety amongst my family in terms of me heading to work, and I found this article to be quite useful. There is a tremendous outpouring of support from the community as well as our affiliation medically and through the university itself. I've put a link there of just resources from the Department of Psychiatry of Western that has linked a whole bunch of useful articles regarding coping with COVID in many, many different aspects. But there is a great network that's developing in terms of peer support as well. I know I would encourage you to look around your community. There are a lot of psychotherapy people that have reached out to medical people and offered free psychotherapy to your group. If it's, I'm sure they'd be willing to share within your community. So I think it's really important that we connect and share resources and try to create a little bit of a safety net that would provide for us. Dr. Mamta Gutton from the University of Ottawa has set up a peer support hotline for an hour every week. Basically, it's a drop-in session to just try to connect the community. That's her quote from there. She's going to do a daily Zoom call to offer mutual peer support. It's not therapy or psychiatric care, but just an opportunity. And the links there for information in order to access that. Just a shout out to residents as well. This is an initiative from the Ontario Medical Association and the Ontario Psychiatric Society through two physicians related to London Health Sciences Centre. They're doing a Zoom call once weekly for 3 weeks that is basically for residents and to try to support them specifically across Canada. The information is on your screen. And again, you know, it's a very difficult time for us, very challenging time for us. It's extremely challenging time for learners. And again, just as a plea, share with us and each other your local and regional offers of help, useful resources. If you want to email CAEP through the website, we will try to compile them and share it regionally from where you are. There's an outpouring of support for the community because they understand the tremendous anxiety and difficulty that we're going to be facing from this point forward. So please be generous, share, and let's continue to connect, and we'll get through this together. Thank you very much.
Okay, so I'm just getting my slides ready here. Can you see the slides? Just nod yes. There we go. Okay, so what I was asked to talk about was command and control in disaster situations. And before I go there, I just want to thank the CAEP leadership for organizing this town hall. It feels really good to connect with an amazing bunch of Canadians that are on the front line, willing to take some risk to look after each other. So it's much appreciated, and I'm honored to have been asked to contribute this evening. Just a few objectives, just very briefly. I want to just touch on the incident command structure, a bit of framing, some framing things that you can do to managing things in a crisis situation, how to run a meeting, some tips and tricks with running a meeting in a crisis situation, talk about SOPs, and a little bit about communication. So lots of people have probably seen this structure before. the incident command structure. There's many different levels. ICS 100 is free online. You can just go to your local provincial government website. You can search it and find it, and you can take it, and it'll allow you to kind of structure a process for managing your team. I highly encourage you to use this format. It can get as complicated or as simple as you want. There's many different levels, 100, 200, 300, 400. But the nice thing about it is that you don't have to be locked in. It's a model for command structure. It's a coordination of emergency response, and it can be used for any type of event or any size, that sort of thing. I've known somebody that's used it to plan their wedding, and I've also known somebody who's used it to plan their divorce. So it's very flexible. The only two kind of mandatory or necessity positions would be the incident commander and operations. This is just an example of what one ICS structure is in a facility in my province. And this is the structure that was decided, and each facility in each area will have their own. A lot of people know what logistics are, the stuff, structure, and stuff of managing a disaster. Plans is always looking about 8 to 24 hours ahead, but this portion here, the operations portion, is always a question. And operations, think of operations as anything that actually touches the patient. So if it's people that touch the patient, equipment that touches the patient, drugs, anything like that, that is your operations branch. And this would be at the facility level. You can use it in the emergency department, and also other departments within your hospital may set up their own ICS structure. So one thing when you're given this task, it seems overwhelming at first. You know, the medicine, some of the medicine is controversial, some of the medicine is straightforward. I propose that this response mostly has to do with logistics and creating capacity. And in order to frame your team, in order to get your team thinking that way, you want to state your aim. So for an example, your aim could be, we're going to develop a COVID response while maintaining essential emergency services. And once you have your aim, you can state your intent. So that's a broad brush stroke of what we're trying to do during this response. And then you can give your intent on how your institution or your organization is going to do it. We're going to develop capacity by decanting the hospital and establish a COVID ward, an ICU, or a respiratory treatment unit, whatever is applicable for your facility. So state your aim that frames your team under the ICS structure, and then state your intent. And that keeps everybody on task. So one of the things that I get asked a lot, I have a military background, is how to effectively run a meeting in a crisis. And what I propose is this structure. Once you have your ICS team in the emergency department or in the hospital, you've framed what you're trying to do by stating your aim. You've stated what the team's intent is. We use a whiteboard, and I like the whiteboard. And we use last 24 hours, next 24 to 76 hours, and next 7 days. And you break it up into your subunits: operations, logistics, planning, nursing, and med services. And you go around the table. So we'll look to our operations person and say, what has been accomplished the last 24 hours? And you jot it down in broad strokes on the last 24 hours. Once that's done, you ask your team for requests for information, or RFIs, or requests for answers over the next 24, 76 hours and the next 7 days. And those are written down. And then you think long-term, the next 7 days. And you can change these timings up here. I always like reviewing the last 24 hours. I like looking at the next couple of days and then looking out a week out. And this will actually generate your actionable tasks that will occur in the next period. So the next day, you do it again. Last 24, next 24, 48, 76 hours, and next 7 days. We take a picture of this board, and then it's printed out, and it's on each of our placeholders the next day. So when we walk in about 5 minutes before that, we're meeting with the incident command structure. We have what we did yesterday on our table, and then we're ready to go again. One of the major breakdowns that we all know is communication. Everybody is stressed. Everybody is getting multiple sources of information. I really like what Rod mentioned about having kind of a single authoritative repository of information that we can go to. And people are using social media. They're getting poor information. It's creating a lot of panic and a lot of hysteria. And as leaders in emergency medicine, we're trying to dial down that temperature so we can get on with kind of the aim and our intent. And what I would say is that accurate information can flow any way that you want it to flow. So if you look at that ICS structure, accurate information can go anywhere as long as it's accurate. When you're requesting resources, however, and the execution of resources, it really needs to go up and down. And we call that economy of effort. If you don't have economy of effort, for example, let's use PPE. If you have 12 people in your department or 18 people in your facility, going to manufacturers, going to community sources, talking to dentists, vet colleges, etc., to try to get PPE, your economy effort is poor and you will not be successful. So what I would say is that information, absolutely, share it, can go anywhere, but any request for resources or execution of those resources should go up and down. What I would say is that a lot of times is that you're told that you need to work the problem. And what I mean by that is that people will bring a problem to you. And what I always say is that if this problem is being presented by an individual group, how would you solve it? Give me 3 courses of actions that you could solve the problem. And if you can't decide on those 3 courses of action, I'll decide for you. And you'll find that when somebody brings you a problem, if you're in a leadership position or even if you're a colleague, they actually know the solution ahead of time. They just haven't gone there. And it's a new way of thinking. And if they're unable to give you 3 courses of action or execute one of those, then that's your turn to get involved, and then you can decide. Just a reminder, the medical assistance chain, we talk about the medical rescue capacity, the medical rescue capacity at an event if something happens, the medical transport capacity of our EMS service, and our hospital treatment capacity. And this is where most of us kind of lie in this area here. And just to note that it's the total medical assistance chain, and we can't have assist Canadians or look after Canadians unless all 3 are robust and well resourced. So kind of here are some of the things that I've learned over my career that I've totally stole, and make no apologies about it, from other people. You got to, taking charge in a crisis situation, here's some kind of top 10. So you got to establish your aim and objective clearly, and you got to establish it early. Yeah, as mentioned before, you got to clearly state your intent. This is the time that you got to act boldly. Everybody's going to be an armchair general and be that hockey coach and a lazy boy and criticize you after, but you got to act boldly. You don't need to be 100% right, but we need to be decisive. The 75% solution with speed is a force multiplier compared to being 100% right and being late. You want to seize the initiative. You want to lead by example in all aspects. So even in the department, besides your colleagues, if you're in a leadership position, but even in the community, in times like this, people are going to be watching what you're doing. I can't hammer home enough, employ the right people. And what I mean by that is separate rank from role. Just because somebody is filling a role during day-to-day operations, they might be your best champion. They might be your best champion for doing a certain job. So that's one thing that you can do by employing the right people, is recognize those champions and give them a task, even put them in a leadership position that maybe traditionally they wouldn't fill. If you do not establish clear and concise report lines, you set yourself up for failure. Multiple report lines with no actionable steps, with something that we call mission command, that's down regulating the most authority to the lowest level to get things done, you may set yourself up for failure. And then everybody knows this, but any time that you're in a crisis situation, you want to be a leader. You can be a good follower. If you can't do those two things, sometimes the best thing to do is just to get out of the way and not be glue in the cog. So that's kind of what I was talking, my top 10. I would say some pitfalls in any sort of plan that you have with regards to working in a disaster situation is you're going to have difficulty getting buy-in. I think in this type of environment, that's a lot easier for some of the requests that you may have working in your emergency departments. You need administration on your side. I've talked about rank from role. Leverage relationships with EMO and EMS. EMO is a great organization in most provinces, and they are helpful, and they can help you pull some levers and push some buttons for resources that you may need. Engage physician leadership. I'm always concerned when I see a ICS structure or health authority with minimal clinical inputs. And physician leadership needs to be involved. And what I mean by that is administrators need to recognize that they will really add to the response employing physician leadership. The emerge department resources should be pushed to the emerge as opposed to the emerge department pulling from the system. And we hear a lot of talk about SOPs. And I always ask, do these SOPs actually exist? And what I would say about establishing SOPs, if SOPs are not rehearsed, they don't exist. So if you create an SOP, it's got to be rehearsed. Some sort of rehearsal has to take place. If it's not rehearsed, it doesn't exist. We already talked about communication, and so I would also encourage colleagues in other departments to use the ICS structure. It's a great way to communicate. So I realize that was fast and furious, but I just want to thank all of you for what you do and for looking after Canadians. And I'll turn it over.
Great. Hi, everyone. My name is Christian. I'm an Emerge Doc in Ottawa, and I want to thank you for the opportunity to speak about some topics related to COVID-19 in terms of some infectious disease topics. And I'd like to thank Dr. McGinty as well. I think it's really important to have our consultant colleagues with their expertise collaborating with us. And so she's taken some time out to lend her expertise to this talk. So I'd like to thank her as well. So we want to address some questions related that came up from the CAEP group and membership. And one of the questions was whether COVID-19 is airborne. And there's been certainly a lot of confusion, especially in the media, regarding this. And the World Health Organization in January of this year took on the precautionary principle, meaning that because we didn't know enough about this illness, the right thing to do was to have the most stringent precautions for healthcare workers, which is airborne precautions. But now with enough evidence that has come out, it's clear that transmission is either droplet or contact with droplets. And so under routine clinical circumstances, when we're routinely seeing these patients in the emergency department, the right thing is contact and droplet precautions, the caveat being aerosol generating medical procedures. So the next slide here talks about a list of aerosol generating medical procedures taken from Public Health Ontario. And basically, is everybody able to see the slides, by the way? I just want to, okay, let me see, because I was trying to share this. Let me just make sure. Is that visible now? That should be visible now. Okay. Okay, sorry about that. So the caveat is about aerosol generating medical procedures. From Public Health Ontario here's a list of the aerosol generating medical procedures, many of which are pertinent to emergency medicine. So of course, intubation, CPR, open airway suctioning, and of course there are issues even with non-invasive ventilation like BiPAP. So the concern is, right now at our center, if a patient requires BiPAP, for example, they present with a COPD exacerbation, we're putting them under airborne precautions in a negative pressure room. The concern is when we have a large influx of patients in a few weeks' time, potentially, there are going to be limited resources and certainly some ethical implications that will present themselves. I would add to this list that nebulizer therapy is the other thing to add in terms of what would be constitute a aerosol generating medical procedure. So this just nicely summarizes how we should approach patients in the emergency department when it's routine care, which includes doing swabs for testing for COVID-19. It's only droplet and contact precautions. And of course, if it's any of those aerosol generating medical procedures from the previous slide, then it should be airborne, droplet, and contact precautions together. Another question that came up was regarding symptoms and COVID-19 and whether GI symptoms were something to be concerned about. I would say that the evidence is very rapidly emerging. I did a PubMed search last week, and there were over 1,200 hits related to COVID-19. So we've taken a sample of 4 studies that are mainly descriptive in terms of the symptoms of COVID-19 and summarized it in a table here. And so what you can see is that by and large, fever and cough are, of course, the most common symptoms that you're going to find. And although GI symptoms, at least when reported in these studies, are not prominent, they're certainly not insignificant either. It's important to also consider adjuncts as well. So to have a higher degree of suspicion, for example, when a patient has lymphocytopenia. Another question that was asked was, well, should we just simply be testing patients with any respiratory symptoms, irrespective of travel? That's a tricky question to answer because I think it's critically important to refer to your local public health agency or institution. We know that testing recommendations are going to continue to evolve, and that's going to be partly influenced by regional transmission and our capacity to test as well. I'm going to use our local example here from Ottawa Public Health, which goes over, this was just updated 4 days ago in terms of who we should be testing. So of course, those that have traveled outside of Canada and present within 14 days of their illness onset, those that have been in close contact with a confirmed or probable case, and also if a person's come from an area of Canada with established local transmission. We also have a higher degree of testing that's required for patients that are healthcare workers, that reside in long-term care facilities or from other institutions such as group homes, homeless shelters, and correctional facilities. The issue is we know that in Ottawa, at least, there is established local transmission. And so for that reason, as of this morning at our center, we have been testing patients that present with respiratory symptoms irrespective of travel, whereas, as Dr. Lang alluded to earlier, in Calgary, they're now moving towards testing only patients that are admitted. So these things are going to continue to evolve. Here in Ottawa, we're waiting for public health to release the latest set of testing recommendations, and this is just something to keep in mind. And so I'm going to hand it over to Dr. McGinty.
Thanks, Christian, and thanks everybody for having me on to talk a little bit about some of the ID and infection control aspects of COVID. I'm going to try and address the specific questions that were asked about PPE, but also speak a little bit more broadly about the concept of PPE for contact and droplet transmission and increased precautions for aerosol generating procedures. One of the questions that came up in the questions that were submitted, but also that I've been asked quite frequently outside of that context, are whether we should be wearing goggles or face shields. And actually, in terms of infection control risk mitigation, the two are considered equivalent for droplet and contact, as well as for the aerosol generating procedures that you would see. So one is not known to be better than the other. I would say that the eye is a potential mucous membrane through which COVID could be transmitted, and there have been 1 or 2 case reports so far of that, but that is by far not the common route of transmission, and it has never been borne out as a prominent route of transmission for any respiratory pandemic before. A face shield has several advantages over goggles because goggles are harder to keep clean. They require washing and reuse, and it is harder not to contaminate yourself while taking them on and off. Face shields are simpler for that purpose. Christian, if you could go ahead. A lot of other questions came up today about how safe is extended PPE, and so there are a couple of interpretations of that I wanted to address. So there's the concept of universal PPE, which is that physicians should, or healthcare workers in general, should wear face masks during their whole shifts in the building in all areas of the hospital. And one is the concept of extended PPE, which is where there is a PPE shortage and you are asked to resource manage and use one mask for as long as possible. Neither of those things is ideal because wearing a face mask continuously puts you at increased risk of contaminating yourself by touching it because the external surface will become contaminated. If it's necessary to do so because of resource shortages, there will be guidelines that accompany that recommendation about how to do this as safely as possible for your region. There are currently no such guidelines in place that I'm aware of in Canada so far, but definitely not in Ontario or at the national level. CDC does have guidelines for this, so if you've been reading around, you will know that in the US they are struggling with this now. The most important thing to remember really about having to use extended PPE is that you must wash your hands much more often. The problem is always contamination through touching the outside of the mask, and so that can be mitigated only by hand washing. Lots of questions and concerns about how to protect your family at home. This is a concern that has come up every time that there's been a respiratory virus pandemic, and it's not a surprising one. Of course, we want to be conscious of the fact that we are potentially becoming vectors for this infection and bringing it home to our families. That being said, there is very, very little evidence to support the fear that we are a substantial source of transmission when we go from our workplace to home, and that is probably because the vast majority of us in these situations are using our PPE appropriately at work, and that is minimizing our risk of infection, which is really the risk that we would present to our family members. And despite this being a prominent concern in the last several respiratory pandemics, there has never been evidence following them that healthcare workers were a prominent source of transmission forward from hospitals. And in fact, most studies identify that sick family members are often the source of infection for the healthcare workers. But in general, I would say to use the precautionary principle. You should wash your hands. Hand hygiene is by far and away the most important part of appropriate PPE for these types of viruses. In addition to that, if your clothes were significantly soiled, like with any other day at work for any other reason or infectious concern, then you might want to consider taking your clothes off before you interact with your family members. If you have a fomite that you carry with you all the time, be very conscious about what you do with it and where it goes. For instance, if you have a travel mug that comes to work with you every day, are you cleaning it as well as your hands? If your stethoscope makes it from your workplace into your home, things like that. But again, hand hygiene is the most important. The washing your hands as frequently as possible is what is going to prevent onward transmission. I'm going to apologize to Rod because I did call it social distancing on this slide, but you're right, it should be physical distancing, not social distancing. There were a lot of questions about what degree of physical distancing was appropriate and what was safe. So I like to quote Dr. Michael Warner, who gave an interview in the press a few days ago, and the statement was reiterated by our Vera Etch, is our medical officer of healthcare in Ottawa, that the safest number to congregate in is 1, not 50, not 10, 1. So that does mean that you should be, or we should be, limiting our social activity as much as the rest of the population is being asked to. Inviting your friends over, your children's friends over, is an increased risk, and we should be modeling the behavior that we expect to see from the rest of the community. So we need to avoid crowded places, non-essential gatherings. If you don't need to go somewhere where there are likely to be other people, it should be avoided, but you should maintain your wellness still by going out to do things like walks or other activities that you can do with your immediate family. And you can still go to the store and to pursue essential services, but you need to be conscious of the size of the gathering that's taking place in those areas. Finally, I wanted to touch a little bit on antiviral therapy, which I know is a hot topic in the media as well as around the hospitals and the emergency departments, I'm sure a little bit too. I wanted to stress that to date, there are no antiviral therapies that are clearly demonstrated to treat or prevent COVID-19. And at this point, we would not recommend that therapies be provided to outpatients or patients within an emergency department who are not being admitted to an inpatient service. Even in that situation, really, treatments should be restricted as much as possible to the context of clinical trials that will help us determine their utility, and or with the discretion of some infectious disease consultation and inpatient hospital management, because none of them are without risk.
All right. Thank you for the opportunity to speak, and we'll hand it back to Kirsten.
Unmute my microphone. Well, thank you very much. In fact, we kept this to a very efficient and appropriate time frame. And I would like to thank everybody, not only who was on the panel, but everybody who tuned in and attended our first town hall. I think it was a great success, and I enjoyed all of the different content. Again, this will be available if you were not able to hear the entire thing, or if you wanted to replay some of it on the CAEP website along with the presentations. And certainly we did get a lot of questions, and some of them we were able to address and some of them we weren't. And so we will work at CAEP to create a kind of a question and answer forum where we can get experts to help answer some of those questions, and then potentially address additional ones and those same ones that we didn't get to today on our next town forum, next town hall event, which will be next Tuesday at the same time. I would just like to mention that the International Federation of Emergency Medicine, of which CAEP is a member, will also be holding a town hall, I believe, tomorrow. And so you can go to the CAEP website to get more information on that. And the EMRAP town halls are on Thursdays, and they're talking about clinical protocols and that kind of thing, and always interesting to tune into. You don't need to be a member of EMRAP or subscribe to get that service. So again, I would like to thank all of our speakers, and thank all of you, and thank CAEP for the opportunity to get all of these excellent Canadians together. And I hope that everybody stays safe and healthy and stress-free. And we're in this together. So have a great evening, and we'll be in touch. Bye.